Welcome to AETCM, the emergency medicine channel. Shall I start, sir?
Sure.
Presented the case of a 25-year-old male who is actually a known case of erectile dysfunction. He came to ER with complaints of painful erection of penis since the last 3 hours post an intracavernousal injection of papaver. On initial 10-second assessment, the patient was conscious oriented. He was talking in full sentences, and air was patent. There was no pooling of secretions or gurgling sounds or stridor. And breathing wise, the respiration rate was 20 per minute with a saturation of 99% in room air. And the auscultation, the chest was air entry was bilaterally equal, and there was presence of no added sounds. And circulation wise, the BP was 120/70 millimeters of mercury, and the capillary refill time being less than 3 seconds, and pulse rate being 110 beats per minute.
Okay.
And disability wise, GCS was E4, V5, M6 with pupils equivalent reactive light of 2 mm, and GRBS was 96.
Okay.
And exposure wise, the temperature was 97.6 degree Fahrenheit, and there was no presence of any rashes or external injuries.
Okay.
And we also asked about the pain score. The pain score of this individual was 9 out of 10.
Okay.
So we had to initiate on injection tramadol 100 mg in 100 ml NS. We was given over 10 minutes with an injection MSet 4 mg IV was given.
Okay.
We had again reassessed the pain score after 15 minutes. He told that pain score had reduced to 5 out of 10. And we had also then we had asked for the adjuncts to the primary survey. We had asked for a CBC-CRP point of care showing a total counts of 9,000 with a HB of 11.2, CRP of 20. And a VBG wise, there was no presence of any acid base abnormalities, and a creatinine of 1, a lactate of 2.
Okay.
So we had asked the sample history. The patient was a 25-year-old male. He is a known case of erectile dysfunction. He was undergone an intracavernosal papaver injection of 60 mg for penile artery Doppler. So Doppler study, and following which he just mainly to look for the penile artery flow, and following which he developed painful erection of the penis, which didn't then resolved by itself, and which was causing urinary retention and severe distress for him.
Okay.
So there was no presence of any prior history of trauma to the penis.
Okay.
No history of, there was no history of any.
If there was trauma to the penis, Dr. Amel, how would the deformity be? What would you expect?
In like trauma to the penis mainly involves if patient is having any straddle kind of injury. Injury to the urethra. So there could be a presence of blood in the meatus. That could be one of the possibilities.
Very good.
So or then another possibility is the presence of deformity in the penis. Deformity along the penis. That can be presence of any penile fracture. That could be another possibility if patient is having a recent sexual intercourse.
Okay.
So that could be another possibility.
All right.
And
so in case of penile fracture, what would the deformity look like?
Look like an eggplant.
Eggplant deformity. If the Buck's fascia is not obliterated and it's not involved, then the patient will have eggplant deformity, which means there will be a swollen penis or an enlarged penis, but it would be not erected. But if the Buck's fascia is involved, then you would see that the hematoma or the extent of the penile or the swelling would extend up to the
Pubis.
Up to the pubic symphysis, and also up to almost up about the mid-thigh region, not below that. All right, go ahead.
So we had also asked him any history of fever or any dysuria associated with it. He denied giving any history of fever, dysuria. He was not giving any history of discharge along the external meatus. And then following which we had asked him the allergic history. The allergic history, he did not give any history of allergy, and the patient, we asked him the past medication history. He was using sildenafil, and following which, that was his past medication history.
Okay.
And past history also, he's having a history of erectile dysfunction diagnosed since the last 5 years. And along with that, he also gives that was the relevant past history for him.
Okay.
And then following which, he asked him the last meal. Last meal was around 3 hours back.
All right.
So following which, we had given him a initial procedure sedation because we had planned him we needed to aspirate the contained blood. So we came to a provisional diagnosis that the patient is having a priapism.
Priapism.
Yeah.
All right. So priapism, what is priapism?
Yeah, priapism means a painful erection of the penis, which is most probably
Can be painful or
painful or not, but it can be a
it's
persistent erection of the
erection
penis.
of the penis.
Yeah.
So, what are the types of priapism?
Yeah, so priapism can be divided into 3 types. So initially, the first one involves the arterial. So arterial is usually non-ischemic.
Non-ischemic.
Or veno-occlusive. So veno-occlusive is usually an ischemic priapism. And then the third one includes the stuttering or recurrent priapism. So these are the 3 variants. So in usually what happens is then
how would you differentiate them?
Yeah, so in ischemic priapism, usually the veno-occlusive priapism is usually very much painful.
Very painful.
Very painful. So painful.
Like our patient.
Yes. So this patient had a veno-occlusive. Suspected veno-occlusive, and for the, in non-ischemic priapism, it's usually due to the arterial. So artery is usually high flow. So in high flow, there is presence of less pain or no pain. So and stuttering priapism is usually the recurrent subset of ischemic priapism.
Okay.
So that's what are the 3 variants of priapism.
Priapism. So, like you were proceeding in this patient, how would you differentiate this? I mean, clinically you told, but in case you need to do some test.
Yeah.
What would the ideal test be?
Yeah. So what we should do is we have to arrange the things for the aspiration. So aspiration of the blood in the cavernosus. So the management mainly involves, in case of priapism, involves the first thing is a corporal aspiration. So corporal aspiration, irrigation, and then if it's not resolving, the application of a alpha adrenergic agonist. So that is the main baseline. Management protocol.
So what would you do with the first aspirate that you get?
Yeah, so the first aspirate which you get, we send it for a blood gas analysis.
Very good.
So that's what we initially do. So in the blood gas, we can, by finding the values, we'll be able to understand whether it's an arterial or venous.
Between arterial or venous.
Right. So in our patient, we had told to arrange for a 18-gauge butterfly needle. So 18-gauge butterfly needle, 1% lidocaine gel. We were told to arrange, and the patient was also we were told to given. We were given
very important. Only lidocaine, not lidocaine with adrenaline.
Yes.
Because end arteries are involved here.
Yeah. And we had also given a procedural sedation before the event because with the ketamine.
Okay.
So actually, it is said that ketamine as an opioid, it also helps in the
ketamine as an NMDA agonist, antagonist.
As it can act as a procedural sedation also, and it can act for help in the tumescence also, reduction of the priapism.
Okay. How much dose and how many times?
Usually, it's given at a dose of 0.5 mg per kilogram per dose. It's usually given up to a maximum of 4 doses.
4 doses.
4 doses.
Okay.
So this is what is the usual it's given. So we had given him the procedural sedation, and we had then with the 18-gauge needle we had what we do is we had 2 individuals. So we had asked for the help of the urologist too, and one person will be aspirating from one side of the caverna. And the other one will be counter aspirated. So what we took.
Alright. Before that, if you have to infiltrate lignocaine, where are you going to give it?
It's mainly along the
site where we are going to insert the butterfly or the 18-gauge needle, or you can give a penile block.
Penile block, yes.
Okay.
So there's 2 ways which we can give local anesthesia.
Again, before that, we should take relevant consents.
Yeah.
Before this, yes.
So following which, what we do is we initially we take the sample, initial blood sample, and send for blood gas analysis. And then what we have to do is we irrigate using saline. So it's about 15 to 20 ml of saline we give a push, and then we give a counter aspiration from the outside. So that's how it's usually done. We can do it multiple times, but even if after multiple times, if tumescence is not achieved, we usually have to retort to a giving alpha agonist, alpha adrenergic agonist. So usually the alpha agent, agent is phenylephrine usually.
Phenylephrine. How much do we give?
It can be the dosage is like we dilute the phenylephrine to 100 milligrams per ml and inject 100 micrograms.
Okay.
So micrograms per ml, 100 micrograms per ml, and we inject 100 micrograms every 5 minutes as needed.
Okay.
So that's what we do. Recurrent times we give, and that is the one of the pharmacological agents which we give for
how does it work in this?
It reduces the arterial flow, the venous flow.
Right.
Yeah.
It reduces the arterial lymph flow.
Lymph flow, yeah.
At the same time, it would cause smooth muscle constriction. So corpora cavernosa by itself would constrict and help the inflow, further inflow obstruction, but it would enhance the outflow. So venous outflow will be more. We have a case of ischemic priapism. No? That's how it acts. Right.
Yeah. So following which, even if after that it's not resolving, then it involves the surgical intervention is required. So that's ultimate treatment. In this case, we had initially given the aspiration. In aspiration, the tumescence had been achieved to a bit, but then we had given 2 doses of phenylephrine was given, following which tumescence was achieved. Yeah.
Okay. So what are the causes of priapism?
Yeah. So
as in, what would the etiology be if you go behind them?
Yeah. So priapism usually can be most.
In our case, it was
pharmacological.
Mostly pharmacological, right?
Yes.
So what are the agents usually?
Yeah, pharmacological agents mainly involves usually the intracavernosal injections of usually vasoactive substances, usually which involves drugs for impotence. So example like papaverine. So papaverine is one of the drugs, prostaglandin E1. So PGE1 and usage of oral agents for hypertension, as in hydrolizin, prazosin and CCBs.
Calcium channel blockers.
So these are the different drugs and neuroleptic medications. So that usually involves the chlorpromazine, thoridazine. Thyroidazine and chlorpromazine. And oral agents related to the erectile dysfunction also. Example like sildenafil. So that also can cause. Yeah.
We spoke in much detail about ischemic priapism. What would the cause be in case of non-ischemic priapism? What would the one possible?
There can be a possibility in case of children. There can be a possibility like sickle cell. So sickle cell crisis. So vaso-occlusive crisis is one of the cause in such individuals. So that also it must be looked out for.
Okay.
If patient the relevant past history of a previous sickle cell trait, individuals must also be looked into.
And also in non-ischemic priapism, there might be a fistulous connection between deep cavernous artery and also the corpora cavernosum. Okay, that might be the this thing, and later on an embolization can be done. Normally that's what we do. And anything else that we have missed out?
Usually we can also, this non-ischemic priapism can be further delineated by using a color Doppler ultrasound.
Right.
So that can also be done. But the treatment mainly involves the non-urgent embolization. Arterial is usually not that emergent, but the venous occlusion is more painful and it's
distressing
more
for the patient. True. Correct. Because how long after this would impotence set in?
Like usually we tell about this priapism as more than 4 hours, like less than 4 hours. So
yeah, more than 4 hours, there is 65% chance of the patient becoming impotent. So as you said, we should diligently act fast.
Yes.
Right. All right.
Thank you.
Thank you.